Good morning. In this video, we are going to discuss the structure of the arteries, the structure of the veins, the structure of the capillaries, as well as the measurement of the arterial blood pressure and other items. And I'll just stop sharing to make sure that we are recording and that editing is clear. Okay, so as you know, the cardiovascular system and the circulatory system in human beings is a closed system. And when we say that it is a closed system, this means that at any time, the blood is contained inside the components of the circulatory system, meaning that at any time, the blood, is present in the heart or in arteries or in blood capillaries or in veins that return the blood to the heart. So this is a closed system, and it is mainly closed because we have those blood capillaries that are widespread in the body and that connect the arteries to the veins. Although however, in insects and lower living organisms, like in invertebrates, for example, as you see, we have an open circulatory system, meaning that we have no capillaries at all, and meaning that the arteries will pour their blood into a cavity that is called the hemocoel, and actually it consists of several cavities that are interconnected to each other, and this blood or hemolymph that spreads in the hemocoel will irrigate the cells or will surround the cells with fluid that contains oxygen and nutrients. The cells will take this and deliver carbon dioxide to the fluid again. And we have a big dorsal vessel here that contains paired slits or ostia. Of course, you don't have to know these details, but it's actually to have a look on the circulatory system in insects and to see that there is no actual pump like the heart in human beings, and that there are no capillaries to have a closed blood system. But although the human circulatory system is a closed circulatory system, yet it allows exchange of materials, just because at the capillary bed and only at the capillary bed, substances are allowed to be exchanged, oxygen and glucose leaving the capillaries to the cells, and carbon dioxide and waste products being returned to the blood. Of course, we have discussed the arteries before. We have said that the arteries are the blood vessels that carry blood from the heart to the organs, and that arteries usually contain oxygenated blood in adults except the pulmonary artery, and that the wall of the artery is thicker than the wall of the vein, just because of the presence of a thicker tunica media or middle layer that contains the smooth muscles. So let's review again the section in the wall of the artery, which we did previously in a lab. So if I take a wedge-shaped section from the artery and enlarge it, so I will have the tunica intima, which is the innermost layer that is in contact with the blood in the lumen or the cavity, and it consists of a thin layer of endothelium, and underneath this layer of endothelium we have the connective tissue that is rich in elastic fibers, which we call the internal elastic lamina, and that's why the wall of the artery is elastic, allowing for elastic recoil. And that elastic recoil is very important for the diastolic blood pressure, meaning that during systole of the left ventricle, for example, the aorta will expand because it will be receiving a new volume of blood, and elasticity will allow it to expand. So because the aorta is elastic, it will expand during systole. But during diastole, elasticity is equally important. The importance of elasticity during systole is to allow expansion. But what happens during diastole? During diastole, the ventricles relax, and therefore they no more pump blood into the aorta. So the blood pressure in the aorta diminishes, and when the blood pressure in the aorta diminishes, the aorta and the walls of the aorta will return to their original place. Because they are elastic, this elasticity, just like elasticity allowed them to expand during systole, elasticity will allow them to recoil during diastole. Is that recoil important clinically? Yes, it is important clinically, because if it did not recoil, the pressure would drop a lot, because you have a very small volume of blood and the vessels are still dilated. So the force per unit area will be very small because of the very small volume of blood. But elastic recoil helps in preventing excessive drop of the blood pressure during diastole, preventing excessive drop of the blood pressure during diastole. Okay? Now we come to the outermost layer, which is the tunica adventitia, and it consists of connective tissue and an external elastic lamina. So one of the major characteristics of an artery is the presence of a considerable amount of smooth muscles in its tunica media, and the presence of a considerable amount of elastic fibers. The considerable amount of elastic fibers, as we said, is important for expansion during systole and recoil during diastole. I will use a new screen in order to elaborate more on this, because this is clinically important. So here, if we talk about the structure, function, adaptation of an artery, the structure, function, adaptation of an artery, so we would focus mainly on the relatively thick tunica media, the relatively thick tunica media, and the presence of elastic fibers. It is rich in elastic fibers. We have elaborated on the elastic fibers on the previous slide or on the previous screen, when we said that elastic fibers allow expansion of the artery. The presence of a considerable amount of elastic fibers allows for expansion during systole, which is very important to, we will say why, and allows for recoil during diastole, and allows for recoil during diastole. Okay, so there is a structure which is being rich in elastic fibers that is related to a function during systole and during diastole. Is it important for the artery to expand during systole? Yes, it is important in order to accommodate the pumped blood. So expansion is important during systole, yes, in order to accommodate the pumped blood. accommodate the pumped blood. Is it important to recoil during diastole? Yes, it is important to recoil during diastole to prevent excessive drop in blood pressure, to prevent excessive drop in blood pressure. So by having said this, we would have said almost all the information you need to know on the importance of richness of elastic fibers. Now we come to the tunica media. The tunica media is made mainly of smooth muscle fibers. And the smooth muscle fibers are important for two reasons. One reason that is, or that applies to all arteries, and another reason that applies mainly to arterioles, because arterioles are very rich in smooth muscle fibers, and because arterioles are the blood vessels that lie just before the capillaries. So in all arteries, the smooth muscle fibers are important to contract, of course. And when they contract in the large arteries, they will propel blood forward. They will propel blood forward. So they're helping the heart to push the blood forward. The heart by being a contractile pump, and the arteries by having those muscles in their walls. Meanwhile, the arterioles, in particular, the contraction of the smooth muscles has a very specific function, and that specific function is not only to contract in order to propel blood to the capillaries or deliver blood to the capillaries, but they contract and relax to control blood flow to the capillary bed, to control blood flow to capillary bed, to the capillary bed, okay? Now, elasticity of the arteries. As we said, the arterial walls are strong and elastic. And this elasticity, as we said, is important both during systole and during diastole. During systole of the left ventricle, for example, it allows the artery to stretch to accommodate the volume of the pressurized blood they receive from the heart. Otherwise, if the artery is not, say for example, we would ask an important question here. What happens, or what would happen if the artery were not elastic? If the artery were not elastic, and I say were because I suppose that it is, or it should be elastic. So if it were not elastic, then what would happen? Like for example, if you have stiffness of the wall of the blood vessels because of cholesterol deposits and because of atherosclerosis or stiffness of the wall of the arteries, what would happen is that every time you pump a certain volume of blood, the artery cannot expand, the artery cannot accommodate the blood, it is stiff, it stays in its place, and therefore the volume of blood generates more pressure because it finds itself enclosed in a very tight and rigid and non-flexible wall. So there would be a marked elevation of the blood pressure, and that's why there is always or almost always a correlation between elevation of the blood pressure and atherosclerosis, or atherosclerosis and elevation of the blood pressure. But elasticity also is also important during recoil, during diastole, to prevent a sudden drop of the blood pressure, as we said. As we said in the lab last time, or in the sphygmomanometer lab, we have two values for the blood pressure. or we define and determine the blood pressure by two values. We have the systolic pressure, that is the maximum pressure in the aorta during left ventricular systole, and it is usually around 120 millimeters mercury, and diastolic pressure, which is the minimum pressure in the aorta during diastole, which is around 80 millimeters mercury normally. So when the left ventricle contracts, this is systole. And when there is systole, there is pumping of blood into the aorta. So the aorta distends with blood, and blood exerts force on the walls of the aorta. And that force per unit area is the pressure, as we said before. So when this is a cross section into the aorta, and this is always the direction of the pressure. It is always perpendicular to the wall of the blood pressure and to the wall of the blood vessel, and pressure equals force per unit area. So it goes without saying that during the peak of systole, we will have the maximum pressure, which we call the systolic blood pressure. And during the bottom of diastole or the maximum relaxation, we will have the minimum blood pressure, which is the diastolic blood pressure. So as we said on Thursday in the sphygmomanometer lab, the blood pressure is the force exerted per unit area on the walls of a blood vessel. And here, of course, this is not inaccurate because it is the force per unit area. We cannot say that pressure is equal to the force, but it is the force per unit area. Of course, as we said during the lab, if you want a site or a location in the circulatory system where the pressure in the artery is most representative of the systemic blood pressure, then it would be a blood vessel that is closest to the heart. It would be a main artery that is the closest to the heart. Of course, the artery that is closest to the heart is the aorta. The aorta is the closest to the heart, but the problem with the aorta is that it is inaccessible clinically. And therefore, when we measured the blood pressure using the sphygmomanometer, we did not use the aorta, but we used another artery, which is the brachial artery. Actually, the brachial artery is one of the branches of the aorta that is still very close to the heart. And usually we measure on the left side because the heart is inclined to the left, and therefore the left brachial artery would be more representative than the right brachial artery. And we said that if the normal blood pressure is 120/80, when you use the left brachial artery, so you would take into consideration that when you use the right brachial artery, it would be 10 millimeters mercury less, meaning that the blood pressure would be 110/70. In other words, if the left arm is inaccessible for a reason or another, or if it is contraindicated, contraindicated means you cannot do this because it is harmful to the patient. If it is contraindicated to use the left arm and the left brachial artery, so in such a case, you would measure on the right side, but you have to take into consideration that you have to add +10 to both to the systolic blood pressure and to the diastolic blood pressure to make up for the difference between the right side and the left side. During the sphygmomanometer lab, we also learned how to measure the pulse pressure, or actually we learned how to measure the pulse. And when we measure the pulse, we measure it this way. we use the index finger and the middle finger usually, or sometimes you can use these three fingers, and they are more or less perpendicular to the artery, and the artery we are using here is the radial artery. It is the radial artery. And that radial artery can, in order for you to feel the pulse pressure, you have to take certain precautions. First of all, your fingers should be this way. They should not be tangential to the artery, but more or less perpendicular. You should press until you feel the pulse. If you don't feel the pulse, you will slightly elevate your fingers because maybe you're pressing too hard, so you are occluding the artery. So it should be the pressure that is just enough to feel the pulse. So the pressure you apply should be just enough to feel the pulse, okay? Less than this pressure, you will not feel anything. More than this pressure, you will not feel anything either, because you are occluding the artery. So this is the second precaution. So the first precaution is about your fingers, the direction of your fingers. The second is the pressure you apply, neither too light nor too hard. Number three, of course, you should know the position of the radial artery, meaning that if this is the thumb, okay, and this is the arm, this is the thumb, so you will have here like a groove in which you can find the artery, and you will feel the artery by compressing it against the bone. This is the radius bone. You will never feel the pulse until you push it lightly against the bone. The best way to feel a pulse is to apply just enough pressure to feel the pulse and to press against a bone lightly in order to best feel the pulse. Why then do we feel pulsation? We feel pulsation because there is a difference between the systolic pressure and the diastolic pressure. For example, if the pressure in this artery is present in the forearm, this is where we measure the pulse, and what we measure is the pulse in the radial artery, and that's why we call it the radial pulse. We do not say radial artery pulse, but we directly say radial pulse. So if this is the radial artery, and this is the diameter of the radial artery during diastole, for example, then when the artery receives more blood during systole, then the artery will expand. So this difference between the pressure during diastole and the pressure during systole gives you this pulse that you feel, this bounding sensation or bouncing sensation that you feel. And that's why what is the definition of the pulse pressure? The definition of the pulse pressure is the value of the systolic pressure minus the diastolic pressure. Usually, if we are in the normal range of blood pressure, usually the systolic is 120 and the diastolic is 80, and therefore the pulse pressure is 40. Of course, when you measure the pulse clinically, you don't say, for example, the pulse is 40 millimeters mercury. You just say, you just count the number of pulses per minute. So you say, for example, that the pulse is 90 beats per minute, and you say that it is regular or irregular. But if you want to calculate the pulse pressure, then it has to, or to determine the pulse pressure, it has to be calculated. You cannot decide just by using your fingers that the pulse pressure is equal to 40. So if you want to have a numerical value for the pulse like here, then you have to measure the blood pressure. Say, for example, I measured the blood pressure for a patient and I found it 110/80 millimeters mercury. In such a case, the pulse pressure would be only 30 millimeters mercury. So you might have a normal pulse pressure, which is around 40, a low pulse pressure, this is low pulse pressure, or you might have a pulse pressure like in aortic incompetence, for example. In aortic incompetence, the systolic pressure might be 160 and the diastolic pressure might be 60, and this is very characteristic of aortic incompetence, in which case the pulse pressure would be around 100 millimeters mercury. And that's why one of the characteristic things in an aortic regurg patient is that even before examining the patient and even before taking the history, just by observing the patient, you will find that the patient is all pulsating. He is pulsating everywhere. The carotid pulse is very obvious. The apical pulse is very prominent. When you put your fingers to measure the pulse pressure, you find that it is exaggerated. Even when you inspect the abdomen, you will find that the abdomen is pulsating like this, okay? Now, are there specific causes for decreased pulse or increased pulse pressure? Yes, of course, but we're not going to cover them all. An example of decreased or very small difference between the systolic and diastolic, when somebody bleeds excessively, and the volume of the blood diminishes, there is hypovolemia. There will be, of course, diminished pumping of blood to the tissues, and therefore there will be diminished systolic pressure. We are expecting the diastolic pressure to diminish, but actually what happens is that the blood vessels constrict to protect the diastolic blood pressure, or to keep the diastolic pressure as it is, and therefore the systolic pressure diminishes, whereas the diastolic pressure stays constant, so the pulse pressure becomes narrow. For example, if the patient has the original normal blood pressure is 120/80, so after bleeding, there would be a marked drop in systolic blood pressure. For example, the 120 would become 90 millimeters mercury. So there is a difference of 30, whereas the diastolic only changes by 5. And this makes here the pulse pressure 40, 120 minus 80, but the pulse pressure here is 50. And here it is important to or it is worth mentioning that, it is worth mentioning that the systolic blood pressure depends mainly on the cardiac output or the pumping function of the heart, whereas the diastolic blood pressure depends mainly on the total resistance of the blood vessels, meaning how constricted the blood vessels are, okay? So this is related to the pulse pressure. And then here are the 3 types of sphygmomanometers we talked about. This one is the mercury sphygmomanometer we saw in the lab. And here is the digital sphygmomanometer that needs calibration every now and then. And here also we have the aneroid. Actually, what needs calibration every now and then is the aneroid. You calibrate it with the mercury, but the digital is good and does not need calibration, but it depends upon the type of the digital sphygmomanometer and how good it is, because it might be inaccurate from the very beginning. Now, when we come to the mercury sphygmomanometer. As we said, it is a manometer, meaning that it is based on the idea of a U-shaped structure, and that when you have a U-shaped tube like this, then when the level of the liquid is the same in both sides of the manometer, then the pressure here will be equal to the pressure there. And this is the main idea of the sphygmomanometer. Of course, this is not a physics lesson, and I'm not going to ask you about the theory behind it, but I'm going to ask you about the biology or the physiology in it. We have seen the parts in the classroom, and here I'll just tell you the theory behind and why the procedure goes as we have explained it in the room. And now I'm going to open a screen, and here I'll tell you that we are putting this cuff of the sphygmomanometer around the brachial artery. So this is suppose for example, this is the original diameter or the starting diameter of the brachial artery. The starting diameter of the brachial artery. The pressure in the brachial artery varies between 80 millimeters mercury and 120 millimeters mercury, normally, even if you don't apply pressure using the sphygmomanometer. When you inflate the cuff and you raise the pressure until, for example, you reach 140 millimeters mercury, then this is the pressure in the cuff. This is the pressure in the cuff around the brachial artery. 140 millimeter mercury that surrounds the brachial artery is higher than 120 and higher than 80 millimeter mercury. So what happens to the artery is that the artery becomes totally occluded, totally occluded. And since the artery becomes totally occluded at 140 millimeter mercury in the cuff around the brachial artery, then you hear no sound because there is no blood flow at all. Similarly, if you drop the pressure in the cuff to 70 millimeters mercury, for example, 70 millimeters mercury, and again, this is the pressure in the cuff around the brachial artery, 70 millimeters mercury is less than the least pressure inside the brachial artery. So if the pressure in the cuff is 70 millimeter mercury, then you can guarantee that the artery is fully open. The artery is fully open. And again, you hear no sound because the flow is laminar flow, or the flow is smooth flow inside the artery. Okay? The problem is in between the two. For example, if this is the column of the sphygmomanometer, so at 125, for example, it is still occluded and you hear no sound. At 75, it is still occluded and you hear no sound. The problem is in this distance. What happened in this column? You heard intermittent sounds. Intermittent sounds. V, 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 or tuck, 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 intermittent sounds. These intermittent sounds are called Korthoff sounds. Korthoff sounds. And why do we hear these sounds? Of course, since we hear a sound, then we have a turbulent flow. And if we have a turbulent flow, in between this upper value above which you hear no sound because of complete occlusion of the artery, and the lowermost value, 70 or 75, below which you hear no sound because the artery is fully open. In between, there are intermittent sounds. Since there is a sound, then we have a turbulent blood flow. And a turbulent blood flow means that the artery is partially open or partially occluded. What does this mean? I'm going to draw again the vertical glass column. So say, for example, that the normal pressure is 180 over 20. So above, when you are above 120, then the artery is totally occluded and there is no sound at all. I mean 120 in the cuff around the arm. And when you are below 80, the artery is fully open. Okay, and you hear no sound at all. In between, you will hear a sound because the artery will be partially occluded. What does this mean? Now we have the cardiac cycle. Sometimes the artery is in systole and sometimes the artery is in diastole. While you are deflating the cuff, here you are deflating the cuff. So the pressure in the cuff is diminishing from 120 to 80. Say, for example, you are here at 100. The pressure in the cuff is 100. So inside, so you have the artery inside and you have the cuff outside. So the pressure in the cuff is 100. Suppose you stabilize the pressure at 100 and you no more deflate. So, but the artery inside is not stable. So the pressure in the cuff, suppose that we are stabilizing it at 100 because we are no more deflating, but the pressure inside is not constant. If the artery is in systole, say, for example, that the pressure inside is 120, then the pressure inside the artery will be, which is 120, will be higher than the pressure outside, which is 100. And for a while, the artery will open during systole. But now, after systole is done, we will have diastole, and the pressure inside, this is pressure outside, the pressure inside will be 80. 80 is smaller than 100, so the artery will be fully occluded. So during your journey downward from 120 to 80, you will always have points where the inside pressure of the artery is larger than the outside pressure of the cuff, whereby the artery will be dilated, the artery will be open, and you will hear a sound due to a turbulent blood flow. And other times in the cardiac cycle, when the artery would be in diastole, where the inside of the artery will be smaller than the outside, where the artery will be completely occluded, and when you hear no sound. So when you hear cough sounds, as you are going downwards, every time you hear vu, then the artery has opened momentarily because the pressure inside is higher than the pressure outside. But when you hear no sound, this means that the artery is in diastole. Why do we hear a turbulent blood flow? Because the artery is not fully open. When it opens partially, and therefore we have a turbulent blood flow. Okay, so here, as you see on the diagram, when the artery is totally closed, you hear no sound, and this is above 120. Below 80, the artery is fully open and you have no sound. In between, this depends upon where you are in systole, or when you are in systole or diastole inside the artery, and what the pressure of the cuff outside the artery is. So these are the steps of blood pressure measurement, including the precautions. Of course, you inflate the cuff above the expected systolic pressure. And if the expected systolic pressure is 120, then you will raise above it like 20 more millimeters mercury to avoid the auscultatory gap, okay, in which there are no sounds, but yet the patient's blood pressure might be 140. Of course, as you know, the cuff is connected to a column of mercury, and then you release the air slowly while listening to the sounds and at the same time watching the mercury column. When you first hear the sound, this means that the artery has opened enough to overcome the cuff pressure, and this would be the systolic pressure. So the first sound you hear is that of the systolic blood pressure, and the first permanent disappearance of the sound would be the diastolic pressure, because at that moment we will have a steady blood flow. So when you have a fully open artery, this is a steady blood flow, or a laminar blood flow, or a regular blood flow, and no sound is heard. When we have a fully closed artery, there is no sound at all, and when we have a partially closed artery, we have a turbulent blood flow. Okay, now I'll stop here, and this would be the content of the lab we did on Thursday, and we will be receiving you will be receiving a lab sheet for this. And then later on, inshallah, you will be receiving another video by the end of the vacation in order to talk about hypertension, capillary circulation, which is already very easy, and the differences between the arteries and the veins. Thank you guys, and see you next time, inshallah.